Okay, so I believe we have a quorum. Does that, okay, very good. All right, so let's go ahead and get started. We're just about, sorry, the boxes moved. So shall we, where'd you go? There you are, Carmen. Okay, wonderful to see everyone today. Thank you so much for the adjustment of coming together virtually. We have a few people that are not feeling well today, and we thought it might just be best if we went back to Zoom for this particular meeting. Our very own Donna Mills is not feeling well today, and so unfortunately she's not able to not only not join us if we had been in person, but also she's not able to join us today. We were going to celebrate her once again, and we will bring her back at the next meeting and ask her to give a bit of time so that we can properly send her on her way. Thank you for those that were able to make the event last Friday. It's always great to get together and see everyone. And Donna was just she was just had so much joy from all the just people making time to celebrate her and to thank her for her work. And it really was a beautiful event. Thank you to the team, everyone who put everything together to make sure that it was a wonderful event, and for a really successful partner luncheon with the Regional Health Improvement Plan as well. It was just great to see everyone celebrating that work and just making time to just sit and pause with the fact that we've done a whole lot as a region. We have a lot on the horizon, but it's really great to see that work coming to fruition as well. So with that, I will go ahead with the introductions. And so do we want to pass it around to keep it sort of lively? I'll go ahead and start with, how about Michaela in terms of my Hollywood Squares? I have Michaela this morning.
Hi everyone, Michaela Arsenault, a project manager at the Central Oregon Health Council, and my pronouns are she, her, and hers. And I'll pass it to Paul Andrews.
Hi there, I think that was me. This is Paul Andrews. I am the superintendent of the High Desert Education Service District, he, him, his, and board member. And I will pass it to Megan.
Hi, Megan Hayes with Mosaic Medical, pronouns her, hers, and I will pass it to Gwen.
Hi, Gwen Jones, she, her, hers, staff at the Health Council, and I'll pass it to Leslie.
I was only just barely ready. Leslie Neugebauer, Senior Director of Medicaid Governance at Pacific Source.
And how about we toss it to Commissioner Adair?
Yes, Commissioner Adair just drove in from Sun River, and I'm trying to see who else is on the other. We've got other screens, right? So how about Gary Allen?
Good afternoon, Gary Allen, Vice President of Clinical Services at Advantage Dental, and I will pass it to Lindsay Hopper.
Hey everybody, Lindsay, I use she, her pronouns with Pacific Source. Nice to see you all. How about I kick it to Dan? There we go.
Hey everybody, good afternoon. Dan Stevens with Pacific Source. Boy, who do I want to pass this to? Can I pass it to anybody? All right. How about Rebecca?
Hi everyone, Rebecca Berry. I'm the Grants and Metrics Manager at the Central Oregon Health Council. I use she, her pronouns. How about Kat Mastrangelo?
I knew you were going to do that. I just took a bite of my lunch. Kat Mastrangelo, Volunteers in Medicine, she, her pronouns, and I will toss it to Iman.
Hi, good afternoon, everyone. I'm Iman Simmons. I am the Chief Operating Officer for the St. Charles Health System. And is it okay if I pass it to Carmen?
Sure.
Thanks, Iman. Carmen Madrid, she, her, hers pronoun, incoming executive director. And I would like to pass it to Marianne.
Good afternoon, Marianne Wren, Director of Integration and Community Programs for Advantage Dental from DentaQuest. I use she, her pronouns, and I will pass it to Brad.
Hi everyone, Brad Porterfield, he, him pronouns, Executive Director, Latino Community Association, Consumer Rep, and Chair of the Community Advisory Committee. And I have no idea who to pass it to, because I joined late. So can somebody help me out?
How about Dr. Sharma? Divya.
Divya.
Hi, Divya Sharma. I'm the Chief Medical Officer for COIPA and the Pine Community Health Center, and a board member here, she, her pronouns. And I don't know who is left.
I think I'm the newest and latest for the meeting, Linda Johnson.
Linda.
Council Vice Chair, and she, her, and hers. And I'm on a very slow internet, so I apologize.
It's okay. I'm slow in general, so we'll just get along fine. How about Kristen?
Good afternoon, Kristen Tobias, Community Health Coordinator for Pacific Source, and I use she, her pronouns. I'll pass it to Eliza.
Eliza Wilson, she, her, hers pronouns, and I am the chair of the Coordinated Entry Committee for Central Oregon, the Homeless Leadership Coalition, and the director of Runaway and Homeless Youth Services for JBARJ. And in a group this large, it's hard to remember who hasn't gone. So if you haven't gone, go next. Rebecca.
Thanks, Eliza. I'm Rebecca Donnell. I'm an innovator agent with the External Relations Division of Oregon Health Authority. I support the Pacific Source CCOs in Central Oregon, the Willamette Valley, and the Columbia Gorge. And thanks for having me here today. Anybody else who hasn't gone, can you raise your hand? Renee, did you go?
I think we have Lori. Oh, and yeah, go ahead. Go ahead, Renee. Sorry.
Hi, everyone. Renee Worth, Project Manager with Central Oregon Health Council. My pronouns are she, her, and hers, and I have no idea who else hasn't gone.
Lori, dive in.
Hi, everyone. I'm Lori Hill. I'm the new CEO at COPA, and just moved here from Los Angeles, and this is my first COHC meeting.
Excellent. Welcome. It's great to have you.
Thank
we have
you.
Commissioner Simmelink with us as well. So Kelly Simmelink from Jefferson County. And how about Trisha?
Hello, everyone. Trisha Wilder, she, her, and hers pronouns, and I am the CCO Director for Central Oregon for Pacific Source.
Okay, and I think that might bring us home. Did we miss anyone? And it looks like Commissioner Simmelink is having an issue with the audio. Okay, great. We will, if there's something, go ahead and use the chat, Kelly, and we will bring your thoughts into the meeting that way. And let's see, Mike Shercliffe, do you want to introduce yourself, please? Mike Shercliffe, I believe we coined him the godfather of dental. Gary, is that, I think that's what we determined on Friday. And so we'll just maybe have. Wonderful. And we have an 815-9716 phone number. If that person wouldn't mind introducing themselves, or maybe that's your audio coming in, not sure. Okay, well then let's go on to public comment. Did I miss anyone? First of all, is there anyone else that, oh, hi, Erin, I'm sorry, I didn't, dive in, sorry,
No,
Erin.
quite all right. Erin Fair Taylor, Vice President of Medicaid Programs and at Pacific Source, and I use she, her pronouns.
Excellent, thank you so much, sorry about that. And there's Mike, go right ahead.
Mike Shercliffe's on too.
Excellent, yes. And we called you the Godfather in case you were not on quite yet. So,
Well, I got on, but I was on the wrong meeting, so I'm on the right place now.
so we're Godfather light today then. All right. So welcome everyone. And really most importantly, Carmen, welcome to your first official meeting. Super excited to have you. And what a joy to get a chance to get to know you a little better through the last few weeks. Just wanted to say how grateful we are that you are on this journey with us and that we get the chance to work alongside you. So the next thing that we have on the agenda is public comment. Would anyone like to offer public comment today? Okay. And certainly, as is customary with us, if someone has something they want to say and you're not formally a member of the board, please know that we will have those opportunities throughout the meeting. Brad, please dive in. Yes.
I never know exactly what public comment's all about, but I just want to celebrate the fact that Healthier Oregon, Cover All People is about to start July 1st, which means that another fairly significant number of immigrants in our communities are going to be covered by Oregon Health Plan.
That is exciting. Thank you for raising that and for bringing that forward, Brad. Public comment is really yes, whatever it is that we want to share that maybe isn't necessarily on the agenda. Anyone else? Okay, so let's go to our consent agenda. We do have a couple of changes for the actual agenda for today. The item which has when next to it, the real data is not going to be presented today. So we will be presenting that in the future, but that item is going to be postponed. And outside of that, I believe that that's the only change. And I'm sort of looking to Carmen if there's something here that maybe I've missed, but outside of that, that would be a change to the agenda. And then we have the consent agenda as well. I haven't heard from anyone wanting to remove anything for further discussion. So if you have no changes, please move forward with the motion or whatever suits the board.
We will also need a vote on the audit and on the finance piece. So.
Oh, yes, thank you. So those items will be moved from info to action, and those are under governance, and that is our audit and the finance committee report.
I move adoption of the remaining items of the consent agenda.
This is Gary Allen, I'll second.
Excellent. Any further discussion? All right. And just to keep us from talking over each other, anyone opposed? All right. So the motion carries. Let's go forward, Brad, with our patient story and our learning today. I'll turn the floor to you.
I apologize, you caught me by surprise. Am I supposed to be presenting something today?
Oh, okay.
I'll ask, Michaela and Gwen, is there something that I don't know that I just missed?
So we are learning today in terms of the transition. And so thank you everyone for offering some grace. And this could be a very short meeting, but I did not realize that that wasn't something that we had discussed. So is there anything, Brad, that you would like to bring forward, or should we, or would anyone else maybe like to point out a patient story or a learning that they'd like to share?
I guess I'll just continue to comment on the Healthier Oregon program. I assume everybody on this call knows about it, but maybe we shouldn't assume. But the Cover All People legislation that was passed about a year ago is kicking in on July 1st, and it's going to cover essentially undocumented immigrants who have been covered by COWEM, may have been covered by COWEM, and I apologize, I never remember what the acronym COWEM actually means. It's a strange string of words, but it's the emergency health insurance that is provided for in cases of an emergency to folks who don't qualify, but are otherwise eligible for Oregon Health Plan benefits. So I think I just want to.
Waived medical, Brad. Looks like we've
What's
got
that?
Aaron saving the day. Citizen waived medical.
Citizen waived medical. That clears everything up. But just the idea, just that we recognize the fact that there's a whole, it's not a huge number, but it's a significant number of adults who have not been covered by any health insurance for many years here in the state of Oregon. And now those between the ages of, well, Cover All Kids, covered the youth under age 19. I think that kicked in a year ago, maybe 2 years ago. I forget, lost track of time. Probably a couple years ago, and maybe 3 years ago. And then this new Healthier Oregon, Cover All People, Healthier Oregon program is going to cover those 19 to 25 and 55 and over. So there's still this gap in the middle of most of our undocumented immigrants in Oregon who are still not going to have Oregon Health Plan coverage benefits. But hopefully, I know there's energy in motion to get the funds allocated to cover everyone. So I'm excited about that. And I just want to, if there's anything that our board can do to push that along, cheer it along, express how important it is to our communities, I'd love for us to do that. Thanks.
Excellent. Thank you for that, Brad. Is that something that, letter of support or anything that maybe that's to our OHA partners? Is there anything here that you feel like we could maybe do?
Yeah, I think always there's an opportunity to advocate around continuing to expand coverage. I think, they're going to be looking at these bridge plans that will be part of the redetermination process. And really the only barrier that exists currently around expanding Healthier Oregon, which is what Brad is talking about, to the entire adult population, was budgetary considerations, that it was capped at 100 million. And so I think it's worthwhile to talk to representatives and to continue to advocate for further expansion.
Thank you for that, Rebecca. Carmen, if we could bookmark the letter of support idea and draft something up, maybe kick it back to the board, and there'd be an opportunity for us to send that in. I think that would be great. And then, of course, engagement with our legislators as appropriate as well.
Absolutely. I think that's a great idea. Thank you.
Of course.
Yeah, and I'd just like to add to that and comment that along with advocacy for coverage is advocacy for workforce expansion. I don't think you can really do one without the other. And I think everybody appreciates the difficulty we're having even now. And I think adding more to behavioral health, oral health, primary care, you name it, is something that we should all be able to stand behind as well.
Excellent. Thank you for that, Gary. You're right. We have a capacity issue. It's sort of like likening it back in the day when we would talk about, well, I have insurance, but I have coverage, but I don't have access. And so really an important piece to the puzzle. Any other comments or suggestions in terms of this topic? Okay, well, look at you, Brad. Saved the day and engaged us in a different way. Thank you for that. Really appreciate it. I'd like to welcome Katie Plum also from Crook County. Good to see you. All right, so next on the agenda, we have COHC staff up. Carmen, do we have the Regional Health Improvement Plan Work Group update? Thank you.
Hello. So for our update today, we're going to focus on the Stable Housing and Support Work Group. We're going to explore their data around 3 of their measures. And we'll look at their current data as well as gain a shared understanding of the limitations around that data. And then lastly, we wanted to share about one of their investments aimed at addressing 2 of their future state measures.
So we're going to start by getting to know the population level data that's used for the Stable Housing and Supports future state measures. You all have indicated a lot of interest in housing and a lot of interest in understanding the population level data and outcomes. So this is going to be super interactive. I'm going to invite everyone to, if you want to use 2 devices at once and embrace your inner teen, you can use your smartphone and scan the QR code on your screen. It'll take you right to the housing data website page, or you can go to centraloregonhealthdata.org, which will show up in your chat in just a moment. And then we'll go to the housing, Stable Housing and Supports priority area together. So take a moment to get there, and we'll meet you there. All right, so just a refresher, here's the main page. Priority areas is where all the future state measures for the RIP are housed. So you're going to come down to the stable housing and supports and select that. And then we're going to scroll to the middle of the page, past the aim and goal, to the measures themselves. So this is when you actually can unmute or use your chat box, because I'm going to ask some questions about the measures themselves. So you'll find throughout the RIP, there's different types of measures. Some future state measures may be more of a process measure. Some future state measures are more of an outcome measure. We know in our organization, sometimes we need process measures and data creation measures to be able to move work forward, to be able to measure and count things to then make improvements. So when y'all look at these three measures, decreasing severely rent and mortgage burdened households, increasing housing choice voucher holders who are able to find and lease a unit, and accurately tracking Central Oregonians experiencing houselessness, which measures are a little bit more of an outcome measure? Really general, don't get too, specific on how we define those, but somebody go ahead and unmute and just speak out, which is more of a outcome measure. Come on, clinic folks.
1 and 2.
Yep, absolutely. Thanks for stating the obvious. You guys know this. So, and then which is a little bit more of a process one?
Number 3.
Right, accurately tracking. We know we have the pit count, but there's some holes in that. And so this is an alternative way to be more accurate in counting, so that when the number decreases, flexes up or down, then the count is more accurate. So then what we're going to do is go a little bit deeper. I'm going to have you all choose a measure, 1 or 2, and I'm going to take you into the measure to look at the data source of where the data is coming from. Because you know that the Health Council doesn't create data. We utilize regional, state, and federal national sources for the data that goes into this. Well, we don't even do it. Foundit does it, our wonderful our platform. So if your first name starts with the letters A through M, go into future state measure 1. If your first name begins N through Z, go into future state number 2. If that's confusing and you just don't know your first name today, pick one, it's fine. This is loose and goose. So for simplicity's sake, I'm gonna click on this blue banner that says measure 1. And both of the measures work this way. And you'll go into this and see a high level overview. You're next gonna go into this little blue bubble that says see latest data. And then you're going to scroll through this text that gives the background. And we're going to go into this teeny tiny print over here on the left. So with each measure, there's the source outlined, measurement period, how it's maintained, when it was last updated. Then you can also explore how the level of disaggregation, who collected it. So I'm going to stop sharing and let you all interact a little bit. Give you a minute to catch up. So get on your own screens if you haven't quite yet. And let's answer some questions about future state measure number 1, or you can just answer the questions and tell us which measure you're looking at. For future state measure number 1 with rent and mortgage burdened households, what's the measurement period?
2016 to 2020.
And when was it last updated?
May 2022.
So what was that lag time?
2 years.
2 years.
2 years, right, okay. And who collects that data? What's that source?
Census data.
All right, anybody remember anything that happened when census was going on?
COVID.
Yeah, take note of that. And then what's the level of disaggregation for this data? How disaggregated does it go? How small does it break it down? Does it stay in the region? Counties, And which counties are included?
Jefferson, Cook, and Deschutes.
Okay. Is there anything for Northern Klamath or Confederate Tribes of Warm Springs?
No.
Yeah, right. Those are our areas too, I guess. So okay, let's look at future state measure number 2. Those who are looking at it. What's the measurement period for this one? This is housing choice vouchers, so much more local-ish. Folks who are looking at that, what's the measurement period for this one?
2020.
Okay. What's that?
I was looking on mine and it said 17 to 2020.
Okay, yeah, so for housing choice vouchers?
Yes.
Okay, yep. And then when was it last updated?
December 2021.
So that's a little bit more recent. What's the source? Where's this data being collected and updated?
Housing Works, Central Oregon.
Okay, so nice and local. What's the level of disaggregation for this one, this measure? It's Central Oregon as a whole, right?
Says for Deschutes, Crook, and Jefferson counties.
Yeah, so it's collected, but not able to pull it out by county or smaller region. Absolutely. And anybody know any of the story or history around housing choice vouchers, how they work, what drives the data, or may not be reflected in the data? Sometimes we do, sometimes we don't. Yeah, so there you go. That's great. So then bringing this full round. So what is one of the strengths to the population data that's available? And what's one of the weaknesses?
A weakness is the lag time.
Lag time. What
A
else?
strength that can be that it includes complete counties, and the opposite is true for the North Klamath and other catchment areas that we also want to look at, including the tribes.
Yeah, so there could be holes in that. And other things that you've kind of come across is that thinking about the census data, there was COVID when it hit, and we know that they're coming out with data now around some of the gaps in even collecting census data and how that's impacted the numbers that we have now. And we know that we don't have the personal impact behind these numbers in the real lived experience of what this means in a person's life. So really nice conversation, nice call out to all those. And I hope this gave you kind of a high level view of the population data that y'all are working with in general, as well as specifically for the housing priority area that we're gonna dive into next. And Renee is going to take you into a community project that the Stable Housing and Supports Work Group has invested in and is supporting that impacts some of these future state measures. And I'm going to share screen again. There we go. Take it away.
Thanks. Okay, so last fall, the RIP Stable Housing and Supports Work Group invested $600,000 in the Homeless Leadership Coalition's multi-year project, increasing continuum capacity in the effort to end homelessness. This project impacts 2 of the stable housing measures in the Regional Health Improvement Plan. One is to increase the number of housing choice voucher holders who are able to find and leave the unit. And the other is to create a way to accurately measure the number of individuals experiencing houselessness. This project was proposed to the work group to increase capacity and address an urgent need to support the coordinated entry system due to the increased pressure put on the system with 96 newly available emergency housing choice vouchers. In a moment, I'm going to turn it over to Eliza, who's going to give you an update on the project. But first, I want to show you where you can find details about this project on the Community Health Data website so you can learn more yourself. So I'll go ahead and share my screen and show you how to get there. So from the Stable Housing and Supports page that you were just looking at, you're going to scroll down to this section of what we're learning, and you can click these arrows and scroll through to see if you can find the project there. It's not there. So you're going to find this, this section here that will take you to the housing collection. So if you click on that, this is everything that's ever been, or most of the projects that have been funded related to housing from the previous Regional Health Improvement Plan and the current Regional Health Improvement Plan. And if you sort by date, it'll bring up the current projects to the top. So you'll see the Homeless Leadership Coalition is the second one. You can click on that and it brings you to the project page, which gives the aim of the project, the background, which work group or priority area it was funded from, which future state measures are being impacted. And then down at the bottom, it gives all of the project details. And then I just want to note that every grant that is given out through the Regional Health Improvement Plan has objectives related to it. And this is really what the work groups are tracking. They're looking at the objectives related to the specific project and tracking those objectives over time. So just quickly, one other way that you can get to the funded projects, if you go to the Community Projects tab, there's the What We're Learning section and then the currently funded projects. So if you go and click on the currently funded projects, this will bring you to everything that's being funded through the current Regional Health Improvement Plan. As quickly as Rebecca can do an amazing job at updating this page, I want to give her kudos for doing all this work. So if you scroll through here, then again, you'll find the Homeless Leadership Coalition project from this page. So, and now I'm going to turn it over to Eliza from the Homeless Leadership Coalition, and she's going to give you an update on the project.
Great, thank you so much. I'm going to try to share my screen if I'm able. Let's see. Okay, can you guys all see that? Awesome. So we did introductions earlier, but I'll introduce myself again. My name is Eliza Wilson, and I am the current chair for the Homeless Leadership Coalition and have been on the board for about 6.5 years now. My capacity serving on the board, like all of our other board members and community members that serve and participate in the Homeless Leadership Coalition, is really on a voluntary basis, and something that my organization, which is JBARJ, has allowed because they see the impact that it has on the community. And that's the same that goes for the board members and other folks that serve in the committees. The HLC has been around since the early 90s and really started out as, I'm sorry, I don't know why it's not letting me, oh, there we go. So it really started out as a community meeting for folks who were doing like-minded things or had like-minded objectives to meet once a month and just network and connect about how to best serve folks who are experiencing homelessness or at risk of homelessness. And in the 90s, in the mid 90s, when HUD developed COCs across the country in all 50 states and 6 territories, the Homeless Leadership Coalition was really the the likely group to take that on. So HUD's continuum of care program model really does what the HLC's first intended focus was, which was to bring people together and have like a collective strategy to improve coordination and services for people at risk of or people who are experiencing homelessness. It also is really to secure funding for programs and projects, improve data collection, and really meet all of those requirements set by HUD for continuums and for areas around the country. Like I said before, Central Oregon Homeless Leadership Coalition is Central Oregon's continuum of care. And I think a lot of times people don't understand that piece is that the Homeless Leadership Coalition is widely regarded and noticed and is in the media, and we do a ton of work in the community and have for years. But people don't understand that we have COCs all across the country, and they have very specific standards set by HUD with really not a lot of money to do those things. So the HLC is not an organization. We're not a service provider or a nonprofit. We really are the continuum of care, and we represent all folks and organizations that are serving folks experiencing homelessness in our community. So that's why a lot of times when we're asked to, talk about issues coming up, we can't really take a stance and say, oh, the Homeless Leadership Coalition is for this or for that, because we really represent everybody. And like I said, my work on the Homeless Leadership Coalition, just like everybody else, is a voluntary basis. So we don't have staff. It's really a ton of work, and it's on us service providers, and we've gotten more and more support over the years to do this work. So the structure of the COC is the governing board of directors, our folks, the board members, and then we have the homeless management system and coordinated entry that's ran by the lead agency, which is Neighbor Impact. And then our collaborative applicant is Central Oregon Intergovernmental Council. We have the large group of general membership, which is over 40 invested stakeholders from different sectors that are concerned about homelessness. And that includes like so many different folks from the Forest Service, education, healthcare, obviously homeless services, criminal justice, the police, emergency response, really so many different folks. And we have a ton of voluntary, folks from the community, just, concerned neighbors and community members. A huge thing that the HLC does is have committees to run a lot of the work that we do in the community. Some of our longest lasting committees have been Coordinated Entry Planning Committee, the HMIS Data Quality Committee, our Street Outreach Committee, Shelter Committee, Community Engagement Committee. We have a Grants Committee and Youth Advisory Committee, which is our newest committee under the HLC. All of these committees really do like those really important mandates that HUD gives us, mandates and tasks that we have to do yearly, things like the point in time count, providing certain types of trainings to our shelters around the region. So each of these committees really serve a purpose for the COC and for the community in doing those things. The Youth Advisory Committee is ran by JBARJ Youth Services, my organization, but is really there to support the whole community. And what that is there's been a huge focus nationally to center folks with lived experience in the work of planning for resources and new organizations and things like that. So folks with lived experience should be able to share with us along the way how systems should be and how they should be created. Our current board members, as you can see, are just like our general membership meeting folks. They're really from a variety of different places. Myself as the chair, I'm from youth organization. We have a continuum of services for runaway and homeless youth, but also for youth in the juvenile justice system. We have Lindsay Staling, who works in the medical field, Aaron Levnick, who's with Legal Aid Services of Oregon, Roger Moore with Housing Works and Epic Properties. So as you can see, we're really a wide range of services that we provide in the community. And that's really important to have a diverse, perspective. We always have someone from the police department, and we're really looking to continue to grow this and have more diverse perspective on the board. We're currently looking for someone in La Pine. So if you know someone who's interested, please let us know. And then also, we always need to have representation from Warm Springs, and that is currently a vacant position as well. HUD really, their focus is collective impact, and like the money that they give us and that we apply for every year, is this making change in our community? They really want to see that. They want to see that through data. So some of the ways that we, collect this information is just looking at how many folks who are experiencing homelessness in our region, and is that information, is those numbers going down? And I want to tell you, that's almost never the case. That's because of, rents. That's because of COVID. There's always reasons, lack of resources. They always want to see whether or not the length of a person's experience of homelessness, if that time that they experience homelessness has gone down. And then also how we're preventing homelessness in the region. Is there a return to homelessness? So what that means is if someone has experienced homelessness, they've been supported and brought into shelter or gone into a rental with support, do they return to homelessness? Really, when looking at this data, we can track if we're doing it well. We can really look at where are the gaps in our community where people are falling through? Where do we need to provide more support to folks in the whole system to make sure that everyone is being served equitably? And we can really do that through data and really look at that information through data in our system. The continuum of care is really, I think a lot of folks love flow charts, and I think it's important to note, just like when we're serving youth, there's really no wrong door, approach when seeking services, and there shouldn't be. So the continuum of care really focuses on obviously prevention. We want to prevent homelessness if that's ever a possibility before it even starts. And then having lots of different places where people can access support. As you can see, like outreach and providing intake and assessment, having emergency shelter, transitional living, or transitional housing. A lot of times when we hear people at the community level talk about how can we, end homelessness. And I think I always try to impress on folks that there isn't an answer, a one-stop shop of okay, well, if we do this, it's going to end homelessness. You really need a continuum of services for folks, no wrong door approach of, depending on where people are at in their lives and what resources they need, just having those resources available, whether that's transitional housing, whether that's more, mental health beds, just emergency shelter, outreach to reach out to folks and build rapport when they're experiencing homelessness already, permanent supportive housing, supportive services. So all of these things are really the focus of the COC. Some supportive services that we currently offer through coordinated entry, and it's a lot of information to understand, and I probably have trained folks 10 times on coordinated entry before they understand the concept. I think it took me a couple of years to understand the concept, and I've ran the committee since it started. So just understanding that when folks are in crisis, whether they're unsheltered or they're at risk to lose housing, this is a way for folks to be connected to services. So they can call this phone number and be diverted and referred to the right organization who can support them. So that is the purpose of coordinated entry, and that is the way that we get folks into support to try to limit the amount of time that they're experiencing homelessness. And it's important to have diversion in there because some people call us before they're already experiencing homelessness. And so if that's the case, we can prevent for folks from ever experiencing homelessness if we can provide them the right support. And I just want to say, because I think it's important to note that if you haven't experienced homelessness yourself or known someone who has, it can be sometimes hard for people to understand that not everyone has the support of friends and family to turn to when they are in crisis. So a lot of us are really fortunate to have a family member or friend who we could call when we were young, or lost our job, or if there's a health crisis in our family, to turn to. Maybe we have a savings, or we have multi-generational wealth, or those types of things to turn to. And a lot of the folks that we're seeing experiencing homelessness, it is not their fault. It's something that either they don't have the resources, they don't have the support. And so us being able to provide the support to them really kind of levels the playing field for folks who don't have that already built into their family. HUD provides limited funding for homeless services. I think that's, I think people already know that. And if you don't, so we do a ton of work as a COC in a voluntary basis with our grants committee to bring, to bring just under $800,000 a year to the region for homeless services. So it takes us months to write this grant and to submit it, and we do it as a voluntary on a voluntary basis because at this point, because we really do have, with the support from the Central Oregon Health Council, we've been able to bolster some of the resources in our community, and really like the way that we're capturing data and make a huge impact on the system. But we don't have capacity as a continuum of care because we were way underfunded for that. So I'll talk more about that later. So with the money that comes to our region from HUD, we Neighbor Impact for the Rapid Rehousing program. Don't have a lot of time to explain that to you folks, but really is to provide rental subsidy for someone in a housing, someone who's not doesn't have a ton of barriers. They just need, like a year of support, and then they start paying for their own housing after that. So this is really like a tiered system, everything from like minimal short-term support to permanent supportive housing with Fuse. So people who really are not able to sustain housing on their own because of disability. So a lot of folks who experience homelessness and are experiencing homelessness for long periods of time is because they have documented medical disabilities. So these are the different programs. This year will be our first year that we have a rapid rehousing program for survivors of human trafficking. And that is young people who have been trafficked, and that's through JBAR-JU services. So as you can see, these funds go really to programs all over the community to provide a variety of services for people experiencing homelessness. So the HLC, we put forward a grant to the Central Oregon Health Council, Stable Housing and Support Group, work group, to bolster our services and the way that we provide services, the way we collect data. And that was really in response to us just learning about the emergency housing choice vouchers. HUD contacted the regions and said, hey, we're going to be providing you guys with this many vouchers. So for Central Oregon, it was 96 vouchers. And they made some stipulations on that. They said, we want to prioritize people experiencing homelessness. We want this to go through the COCs. And this is really the first time that HUD has done that. And it's been super, super exciting to see that prioritization and to prioritize preventing people from experiencing homelessness. So when we heard like, hey, we're going to need to, you know, connect 96 households to housing, people experiencing homelessness to housing, you know, as volunteers, that was really scary. How are we going to do that and do that in an equitable way when we're really, you know, already, you know, operating, really having a hard time doing what we're already doing. And so in order to do that, we applied for this funding and asked for support from the Central Oregon Health Council to really bolster coordinated entry and launch a regional quality by name list. Renee, I think it was Renee earlier in the meeting, talked about PIC count. That's also something else that's the COC does yearly, which is just a yearly count, snapshot, you know, 1 day count of everyone that we can find or working with already, folks in the community who are experiencing homelessness in January. Well, people try to stay warm in January. It's hard to find them sometimes. So it's not a great snapshot of what's really going on in our community. And so if we were able to, you know, have a running count of like everyone who's currently experiencing homelessness, then we can do a better job of asking for funding and bringing more money to the region to support folks. And then also to have, once we identify the folks who are experiencing homelessness, having housing navigators who are really going to support them in breaking down those barriers and getting them into housing that they need. So, and then to provide landlord engagement, because we need to have time and space to connect with landlords to explain to them, yes, these folks have barriers, but we're going to support them while they're in housing and make sure they're good tenants, and we're going to support them with the funding to keep paying rent. And then also to fund and pay for folks with lived experience to be included in this process and really, you know, tell us if we're doing a good job and what we need to do better. So objective 1, recruit and hire and retain the housing navigator and coordinated entry positions. We have done that. We've hired everyone and we're fully staffed. We have Tony at Don's House, Jara at Redemption House, Casey with JBarJ Youth Services, and Caitlin, who's our coordinated entry generalist, and is now moved into a coordinator role. And then we also have the landlord navigator position at Housing Works. Objective 2 is to improve housing choice voucher success rates and take advantage of all received emergency housing choice vouchers. And I want to say, like, we have totally rocked this, because every time I meet with Housing Works, they're like, wow, you guys, we were worried with giving this to a voluntary, you know, like a committee that's all no staff committee. And so with this support from the Health Council, we have leased 62, it's more than 62 now. I didn't update this number since the last 2 weeks, and more than 62 emergency housing choice vouchers or people are already in housing, which is really tough to do in this market where there's hardly any open units in that price range. So we have 96 total. I think we're more into the 70s now of folks who have been leased up. That's you know, 70 households, people, and I want to say I think it's like 70% of them were homeless. And that's not doubled up homeless, that's living on the street. So that's a huge win. And that's really due to our coordinated entry team, Housing Works, Thrive, so many other folks who have supported this process. Another objective, objective 3, is to really enhance coordinated entry system. If our coordinated entry system is working well, then we will be able to move people through the system. What that means is people who are experiencing homelessness, move them into housing quickly so that they're not on the street longer and creating more barriers in that system. So we have increased the cadence of coordinated entry meetings from like once a month, I think it was, I should know that I'm the chair, to weekly. So we're now meeting weekly for case conferencing. We wanted to develop a quality assurance process for the phone line, which has happened. We've already started training folks who are doing that on a voluntary basis. and then to continue, and then also like, you know, the standards for the program, which we're working on right now with a group of folks. We've started doing standard reports, which we've just been working with so many different, you know, Oregon Housing and Community Services, Built for Zero, doing a lot of work with coordinated entry, which is showing, and that's really why we have more than 70 people housed in the last couple months. Built for Zero, I kind of name drop that. Really, it's a national movement, is what I like to call it. It's a group who you pay in to be a part of their cohort, and they teach you how to use data to impact communities and to impact like homeless services, and how to really reduce and end homelessness, which is called functional zero. So what that means is not necessarily like no one will ever become homeless again. It means that when somebody does become homeless, it's very brief, and we have support to put people into so that they don't continue to be homeless, and we don't have the increase yearly that we see. Communities really start by focusing on data through coordinated entry and through other aspects, and creating a by name list so that we can always know who the folks are who are experiencing homelessness in our region. Our priorities for Built for Zero are chronically homeless folks and veteran homelessness. I want to say, like, our community, starting with Built for Zero and finishing our first cohort, we're really ahead of the game for Oregon. Just a couple weeks ago, we met as COCs across Oregon with COIC and Neighbor Impact and other COCs in Oregon, and we heard from the state that they're going to be investing in Built for Zero and want it to be a state initiative. But we've already started. We've already started the work, and we're already moving towards better systems and improving the systems for folks. So it's exciting to be ahead of the game. That doesn't always happen. So transitioning from, and if I'm going too long, let me know, because I did not set a timer. Transitioning from an annual point in time count to a real by name daily, like knowing who's experiencing homelessness every day. What is that going to do for us? That's really going to help us understand our population better. We get every year after the PIC count, we get tons of emails as a continuum asking, you know, who's experiencing homelessness? Are those people from our area? You know, there's some false narratives out there saying, people think truly that folks move here to experience homelessness because we have a lot of resources, and that's just not the case. And I think this is really important for us to capture this data, because we're able to say, hey, today, this is how many people are experiencing homelessness, and we have 7 months of that data. So what we're really focusing on now is to improve data input. So I think we have like 84% of our shelter programs and street outreach input data. And so we just want to make that 100%. And like, so really working on accurately measuring the amount of people in Central Oregon who are experiencing homelessness on any given day. And the way that we do that is the service is providing support to service providers so that they can input that data every time they meet someone new. And we can take people out once they've been housed or once they've moved to a different area, and really just keeping track of those folks so that we know, and we can better, we can better allocate resources and see who those folks are. Are they youth? Has the youth number grown? That type of information. Excuse me.
So Eliza, we are running a little late on, or a little short on time. And so I'm not sure how much longer your presentation is, but we also want to make sure that we would have this as a benefit to the board to share after as well.
Yes, and I apologize because I did not create this presentation, so I didn't know how long it would take me, and I did tell folks that before I started, so sorry about that. I think, let me look.
And I love your passion and knowledge. We could probably spend a full meeting on this topic. And I do, for the board's edification, we are going to ask that the HLC come back with some of the COIC staff so we can share with you the system and kind of some of the changes that have happened that we won't be able to get into today.
Absolutely. I think I do have quite a few more slides, and I apologize for going late. I do have a ton of passion about this, and I could talk for hours about it. I'm gonna just leave you with just that the contribution from the Health Council, what it's really given the community is going to be like long lasting supports and data, so that we can make so even like our politicians can make good decisions and know information about folks experiencing homelessness and prevent it. And yes, I have a lot of passion. I've lived experience of homelessness, and I bring that to every meeting and all of the spaces. So yeah, thank you guys. And if I need to come back and provide more information, I can. Thank you.
We most certainly will. And your knowledge and your passion and your experience definitely just shines through. So I feel, I really want to make sure that we harness that and bring you back. But how about we chat offline too, so we can tee that up for the discussion that'll be hopefully in August.
Yep. Awesome.
Okay.
Thank you guys. Have a good day.
Well, before we have you peel off, does the board have any questions or is there something that you'd like us to bring back also?
I think not something to bring back, but I just want to share deep appreciation. Like, this work is so critical and it's very rich what you're doing. Like, it's amazing to see how this has evolved over time. And so I just want to say how much I just really appreciate your leadership and passion around this really critical topic.
Thank you so much. I just want to say it's really hard to explain all of these things in a short period of time. Because it's so much information. So I really appreciate that, Megan. Thank you.
If it was easy, we probably have it solved by now.
Yep.
So true. Well done. Really proud to work with you, and more to come.
Thank you, Tammy.
Of course. Okay. So next we will move on to our financial audit for 2021. And before I turn it over to Matthew, I also want to welcome Justin, who joined us as well. And so with that, I'm not sure if anyone else joined us, but I did notice that Justin was able to join us. And so Matthew, how about I turn the floor over to you?
Yeah, thank you. Appreciate it. You guys can hear me okay?
Sure can.
Okay, so who's going to run the slides for me? It looked like I saw it. Okay. I see a hand waving. I'll give you the page number at the very top. So okay, well, it says 10 of 33. Okay, so it's in a packet. Well, what we'll do is I'll say 2 pages forward or something like that, and we'll get on the same spot, so I don't have to worry about the page number. Okay. Looks like I was starting a little bit late here, so I can kind of zoom through this.
We are okay on time. If you have the time, we are okay.
Okay. All right. Well, I'll go, medium speed. One thing I'd like to know is, has the board had a chance to review these financials already, or is this the first time they've seen it?
So they are in the board packet, but outside of you will be our first entry into going over this material. How's that?
Okay.
Does that help?
Okay. Yep,
Okay.
It does. So is question, comment, feel free to interrupt, chime in, no worries. There is a dashboard included in the presentation here. That's going to be, some more of a, not necessarily numbers specifically to the financials, but they're going to be key performance indicators that I like the board members to be aware of. Oh, already have it right there. That's beautiful. Okay. I'll go over that here in a little bit and, kind of highlight a few numbers that I think board members, especially those that are interested in the financials, should be aware of just as part of due diligence. So Matthew Hamlin, CPA, I've been the financial statement auditor for COHC for a handful plus years now, worked with Donna and her team directly. There's a lot of time and effort that goes into this behind the scenes. The pretty little wrapped up package here that is the financials, is what you guys get to see. but the time and efforts by myself and by the team, the management team, of course, sort of behind the scenes here. So big thank you to Donna and everybody for being responsive and timely and professional and as expected. And I appreciate all your help. Let's do 2 clicks to the independent auditors report. So the trained eye will realize that this report actually looks a little bit different this year. The AICPA, my boss, that tells me how to do my professional work, changed up the look of it. It's pretty, in context, it's pretty similar, but you'll see they've put the opinion right at the top, so you know exactly what you're getting right from the get-go. And they made some other changes that help describe the process, responsibilities, and so forth of each party. If you're curious about what my role is as the auditor and what the role is of management for this audit, this breaks it down beautifully and summarized. A key point here is I do plan to issue an unmodified opinion, which is the best opinion available. Let's go 3 clicks, I think. Yep, 3 clicks. You'll notice the big red draft. Yes, of course, we are in draft form. Essentially, these numbers are final. The disclosures are final. We're waiting board approval. Certainly, there are things that can be changed. At this point, that would be in the disclosure, the note section. If you feel very strongly, because these are your financials, not mine, not management's, if you feel very strongly about a certain disclosure, feel free to pass that through to Donna and her to me, and we can tweak some language. I'm comfortable with any sort of tweaks as long as it's not misleading. Okay, our statement of financial position, or balance sheet for those in the for-profit world, compares our assets, liabilities, and what's left over. That could be equity or net assets for a nonprofit. The net assets for a nonprofit are a little bit interesting because you have restrictions or designations that come into play. So a net asset without a donor restriction or without an outside third-party restriction allows the board to do what they want with it. A board designated amount you see here at 8.8+ million, that says that you've designated that or earmarked that funding for a specific program, topic, reason. And it's 0 this year, but we have no temporary restricted or outside party restrictions at this point in time. Okay, and then the very top where it says in the net asset section, the without donor restriction undesignated, mean that's funding that is free and clear. You can do what you want with. Okay, so like I said, that's what's the organization owns of itself. That's essentially assets less our liabilities, right? So our assets, mostly cash, mostly certificates of deposits, that makes up substantially most of our assets at this point in time. We have a little bit of accounts receivable and prepaids, but current liabilities, I'll talk about the change in cash at the statement of cash flows briefly, but all you need to know is a big decrease in cash this year, but there's reasons for that. It was expected, actually. The current liabilities, not much going on outside of our grants payable. So that is amounts that we have earmarked to be paid out to grantees that weren't yet cashed at this point in time, at the end of the year, 12/31/2021. Okay, so the organization is very lean from an assets versus liability standpoint. And like I said, of the 19.3 total assets, 17.1 are actually owned by the organization, free and clear of creditors. Next page, please. So this is a statement of activities or income statement or P&L for those in the for-profit world. You'll notice here that the big chunk of our support and revenue comes from Pacific Source. That's probably not a surprise to anybody in this room. Mostly for 2021, with no shared savings benefit, was the contracts with Pacific Source that drove the revenue this year. Okay, expenses increasing by about 1 million year over year. We will review that on the next page, which breaks down the expenses into more detail. Our change in net assets or net loss in the case this year, 416,000. Okay, so you hear, the next page, please. you hear the terms big decrease in cash and a loss, and maybe a red flag goes up. But again, there's reasoning for that, and I'll touch on that in cash flow, the statement of cash flow, which better describes what's going on. So this statement here, the statement of functional expenses, is unique to nonprofits. You won't see this in a for-profit financial statement. This breaks down expenses by both category and function. So what type of expense was it and how did we use it? You'll see the columns here: program services, management in general. Program services is mission-based funding, and then a management in general is the oversight of the organization funding. Okay, so depending on what bucket it fell in, that's what we use that expense for. Community impact funds, also known as grants awarded, grants out. Certainly the major expense that you see here on the statement. Salaries and benefits, another big one, but the salaries and benefits are actually pretty lean compared to the overall operation of the organization. So between those two and your program expenses, that's 95% of our total expenses. The rest of the categories are pretty trivial. Next page, please. This is the statement of cash flows. I like this report. I mentioned, the decrease in cash, the loss, but here's really what gives us what happened during the year for the organization. This report tells us where our cash is coming from and where we spend it. I'm a big believer in the loss or income, or the increase or decrease in cash isn't as important as the why. And this gives us the why. So you'll see here, just above the first subtotal, you'll see a large $8.2 million out. That's the JMA settlement payable. We were expecting that. That was money that originally was going to flow back to Pacific Source, but long story short, Pacific Source says send it out to others. And so that money was not ours in terms of COHC money. That was expected to belong to someone else, and it went. So that's obviously the big chunk here, right? With a net change in cash or net decrease in cash of 5.7, almost 5.8 million, that's the reason. That was expected. That's what COHC was supposed to do. Without that, cash flow would have been positive. So I bring that up because when you look at the loss and you look at the decrease in cash just from the balance sheet and the statement of activities alone, that doesn't tell the whole story, but this does. Okay, so we had some cash come in on a net basis, 1.9 million, our second subtotal here from the CDs. So we liquidated a little bit more CDs than we invested to help with the cash flow. And the QIM withhold payable, about 440,000. That was also a nice chunk out. The reason these two amounts here, that QIM withhold payable and the JMA, the reason we have such a small change in net assets is because those expenses were actually accrued and were incurred in 2020. The cash flow just didn't leave yet. So that's why our net loss for 2021 is actually relatively small compared to the cash outflow. And since the cash out hit in 2021, that's why you see that big discrepancy here. Any questions on the basic financials, the basic numbers before we go to the dashboard? Usually in my experience, there's a question, but somebody doesn't want to ask it. That's okay. We'll move on to the dashboard. Yeah, click over the dashboard for me, please, Gwen. She's working. There it is. Okay. This is those numbers and maybe a little bit more of a digestible format. These are key performance indicators. Not all of them do I think are critical to the organization, but some of them I want to highlight. The very first is the acid test. If anybody ever went to, maybe went through high school. I don't think they touch on this in high school accounting classes, but if you went to business classes or an accounting class in college, one of the first things you learn is acid test. Do we have enough money to cover our most currently due payables? That's pretty important if you're a business or a nonprofit owner. What this number says is for every dollar of current due payables, we have about $9 in liquid assets to cover those payables. So that's a very good figure. We're very lean and not over leveraged. Days cash on hand without donor restriction. So this essentially means at that point in time, at the end of the year, the organization could operate for about 500 days, 499, without a single dollar of inflow. That's a good figure to have. Operating cash flow, yes, it was a large negative, but we discussed why. Working capital without restriction, so 17.1 million plus. In theory, to kind of highlight this, what this means is banking is not this simple, financing is not this simple, but in theory, if COHC decided they wanted to bring on debt, and every time I say debt, Donna scrunches her face and says, so if the organization did, this is in theory how much you could collateralize your assets to get a loan. So you could say, bank, we can get a loan for 17 million without really any concerns of yours of it being paid back. So we have those assets that are not subject to debts. This is after debts. So if you want to look at it from that perspective, or another perspective is this is how much money we could invest in a new project or a new building or whatever it is without, in theory, hurting the organization from an operational standpoint. Okay. Personnel as a percentage of total revenue, very, very low, very, very low. And I mentioned that before. Based off the total budget, how much you spend on people is low compared to other nonprofits. Program as a percentage of total, well over that 75%. A lot of people maybe say 80, but it depends on the organization, the type of organization we're talking about, but well above sort of that peer threshold. And that means almost 94 cents of every dollar is spent on the mission-driven services, which is great. Operating margin, yes, is negative. We know why. And for me, this year, especially is a who cares. The bottom one though is important. Anybody in the room that's not aware that Pacific Source is a major funder, the predominant funder, substantially all of the funding of the organization. I'm sure, like I said, that's not news. If the contracts between COHC and Pacific Source were to change materially, that would materially affect COHC and its operations. Okay, let's go back to the financials and drop down one page. Testing Gwen now and her navigation skills. Yeah. Okay, a couple more. Okay, there we go. One more back for me, please. All right, so note one here. This is the notes to the financials, and I'm almost done here, guys. I need 1 minute. This section is essentially narratives of the policies, procedures, methods of calculation that are the backbone of the basic financials. What I mean by that is without this narrative, you wouldn't really know how those numbers got to where they are or how they're calculated. So for those that are curious and for those that want to kind of get the gold star for their due diligence, please read note one here, the significant accounting policies of the organization, because that's going to be a key one for you to be aware of. 5-10 minutes on your own time. The other item that I want to highlight, I won't do any sort of page navigation here, but please be aware inside of the notes, the financials in 3 different places. Significant related party transactions. So related party, as we all know, is if you're an important person to COHC, whether it be on management or the board or the finance committee, and you're also an important person, a decision maker in the organization or the business where you work. If those 2 entities have transactions together, significant transactions, that gets reported in these financials. That's the reason you sign those conflict of interest forms and hopefully recuse yourself on certain decisions if you have a related party transaction. So as required, receivables between related parties, payables between the related parties, and large revenue streams between related parties are disclosed here in these financials. That's not a bad thing. Doesn't mean COHC or your entity you work for is doing anything wrong. Just has to be disclosed. Okay, any questions for me? And happy to address those now.
Matthew, thank you very much. Is there anything that, because you've been with us for a handful of years, as you've mentioned, is there anything that you are tracking that sort of you think we should be keeping a keen eye on?
Yeah, you know, it's funny. I think you guys asked me that last year, and I wish I could give you something. I mean, the key performance indicators are certainly something to review. You always want to watch for that. The acid test, I believe, is the most, and days cash on hand. Those are the two that I think actually could affect COHC. But the key here is the relationship with Pacific Source. If that just has to be monitored, and obviously how that goes, so will COHC. Outside of that, you just monitor your cash and monitor how liquid you are to cover your payables. It's never been a problem for COHC. I know funding has decreased, but outside of that, the organization's very lean and very clean. What I mean by that is well positioned to adjust to the times.
Excellent, thank you.
Yeah, and one final note for me before I log off. A few people in the room already know this, but this will be with Donna. I am riding out into the sunset. I will no longer be working with COHC in an auditor capacity. I want to let the board know that, and you know, management, that if well, as you go into your RFP process, I'd be happy to provide some names or some referrals if that's needed or wanted. But I sincerely appreciated my, I think, 5-6 years working with the organization, and enjoyed working with the team. So thank you all, and good luck in your next relationship with your CPA.
Matthew, you've always been able to really give us clarity and help us to look into the things that we should be following as a board of directors. And so I appreciate your layman's approach with a lot of detail as well. It's speaking for myself, it's been very beneficial. Really appreciate it.
Yeah, thank you, Tammy. I appreciate that. Okay, everybody, take care and enjoy the rest of the meeting. And
all our best to you.
Yeah, thank you. Thank you. Bye, everyone.
Okay, we do need, if we don't have any other questions, we do need to accept our audit. And so I welcome a motion, or if there's further discussion, happy to facilitate that too.
And Tammy, the finance committee went through the audit and did make a recommendation for approval to the board, just so the board knows that as well. And I'm happy to make the motion to approve.
Wonderful, thank you. Do we have a second?
With the endorsement of the Finance Committee, I will second, not otherwise having any detailed information.
Excellent, thank you, Gary. Any further discussion? Okay, and we'll do the same. So anyone opposed? Okay, so unless someone states otherwise, the motion carries. So next on the agenda, we have the Finance Committee report. Megan, go right ahead.
Okay, well, a big part of the finance committee was the audit review. So that's one part of it. And then the other area that we've been spending time on is in the quality pool payout. And there is going to be coming to the board a proposal for an enhanced approach to the payout of the dollars that are more performance-based. The committee has tasked a work group to work with Pacific Source and the Health Council team to really assess this different approach to make sure it will work across all different provider types, and have the intended outcome of really continuing to drive efforts around our quality performance. So we have one more work group meeting to work through a couple details, and then it will go back to the finance committee, and then we'll be bringing it to the full board. And it would be for payout for the 2022 year. Oops, I think you're on mute, Tim.
Yes, of course, somebody had to do it. Okay. So do you need further feedback from the board, or do you have everything that you need?
I think we have what we need right now, and we'll just bring it to the next meeting.
Okay.
Oh, and one other update that I think will be of interest for the board. There is going to be a presentation from Pacific Source on cost of care. They have been doing a lot of work on their data and analytics. team at looking at cost of care across different CCOs. So they've been working with, I think, Tricia, Lane County is the most recent CCO on their cost of care data, but they're going to bring it to our CCO in August to the finance committee, and then we'll bring that update back to the board.
Excellent. Okay, wonderful. Thank you, Megan. Anything else?
Nope, that is it. Thank you.
All righty. Well, then I'm going to hand the floor over to Tricia for our CCO Q1 2022 performance metrics.
Hello, everyone. As you may recall, we discussed this early on in the year to narrow it down from what I believe was about 16 metrics down to these 8 that I will report out quarterly. We're a little delayed in this report, and this data is a little delayed because normally I would have presented in June, but June was a CAC board gathering. So on with that, I will start. If you see the boxes that are in gray, those are the headers. So quality and member experience is where I will start. We'll start off with what's in the yellow. So currently we have 8 metrics that are close, but not at target. And I don't know how many of you are out there watching and rewatching the original Top Gun, but I will say there are no points in this game for second place. So stealing that straight from the movie, that's why this metric is yellow. So we really want to impress upon, while we have been successful in this space as a community, that we are close in a number of places, but not quite at the mark. So the 2 places where our quality metric team and population health is working closest with most of the organizations in this room is with the well child visits and immunizations. Currently, well child visits are and this is data from the end of April, so a little more recent, trailing by 1.7%, and immunizations is trailing by 3.4%. So I'm not going to get into any more weeds than that, other than just for you to listen in the clinical spaces and to continue to support this important quality work, because this will be a big center point, as Megan mentioned, to our costs of care. There are places where you can look to decrease costs, but then there are also opportunities, and quality work is definitely one, to ensure that we're capturing all those dollars that are on the table. Next, I'll move to the gap analysis pertaining to the availability of mental health services is being completed. And I think, I'm not going to read these all in their entirety, but I think the important part here to know is that the quality team is engaging in a statewide PIP work group. And they're going to present the highest ranking barriers. These barriers are being identified internally and externally with strategies. And most recently this week at the provider engagement panel, which is the Central Oregon Health Council's medical gathering, if you will. They met this Wednesday and reviewed and accepted feedback from that group. So those are the updates in those spaces. Do we want to pause just for a moment before I go on to CCO 2.0 requirements?
Any questions or comments?
Tricia,
yeah.
Is there anything that you need from the board in support of moving the dial on the areas that are causing the yellow?
I think continued, our population health team is working so closely, specifically Megan with your group and Justin and St. Charles. And, it's really attention to the individual member and working these gap lists. And I can only imagine that in the space of workforce shortages, how challenging this must be in those spaces. And then I just would say thank you to everybody who is committed to this work and shifting to a higher focus on quality as we've come out of the pandemic or becoming endemic. So I don't think there's any specific board request other than individually just allowing opportunities and having the awareness that these targets last year and this year were rebased on a 2-year glide path. So we are below even where these metrics were pre-pandemic levels, where we have previously been successful. So our targets are lower and we're still a little behind. So continued focus and work in those spaces. Some of these will improve, the ECQM metrics will improve throughout the year. That's a natural process. And I know we're working hard to help establish patients, doing very specific well child, postcard campaigns and other work with population health. So was that a helpful answer?
Yes, that there's a lot happening to move the dial in place.
Yeah, I think so. So if anything, we're half yellow, half green in that space, but we don't want to be too optimistic in this space, and there's a lot of work to be done. Okay, moving on to CCO 2.0 requirements. We don't have any current data on our value-based payment framework, but we will say that we left the end of last year at 59%. So this isn't a metric that we anticipate that staying in the green. If we move on to the second metric in 2.0 requirements, the partnership here is with Oregon Healthcare Interpreters Association to both train and certify culturally and linguistic responsive healthcare interpreters. So we had 12 complete the class in Q1. We have another 16 signed up for the spring workshop. So that's 28 in Q1 and Q2. We're monitoring who is testing in those space while we don't have exact names. As we know, training is one thing and certifying is another. There is the people need to pay back if they don't take the exam. So there is a very, very strong incentive to ensure that people take that exam. So the person who oversees that program here, Gretchen Horton Dunbar, is confident that we are still green and on target in this space, and that while these interpreters are across the state, that this will have benefits for Central Oregon and all CCOs in that space. So before I move on to financial stability, does anyone have any questions there? Okay. So 2 sentences here that are very strong in the financial stability. I'm going to read these so I don't mix any numbers up, but the following financials report a year-to-date operating gain of 7.1 million ahead of the budgeted 6.0 million. Now I'm going to read the last sentence as well. There will be the 2022 JMA shared savings is currently estimated to be a future shared savings of 1.3 million. So very green on the budget moving forward right now. And again, with the quality pool payout yellow, this is an exciting month for quality dollars. We're anticipating to hear from the state on what our 2021 payout will be, just to get an idea of how large of a potential opportunity this is. We're anticipating about $15 million coming in through the quality incentive metric program. So if we can continue to be successful in those places, that's a really good place to put focus. It's a little, as we look at the 2021 payout, I do want to call out, there was about $2 million on the table for the COVID emergency outcome tracking measure that Central Oregon will not meet. So when we think about which would have then meant a $17 million payout. So when we think about how important this work is both for quality and clinical care of our community, these additional dollars both flow in to also help us move forward these metrics. So just something to keep in mind. And again, we're close in a lot of places, but not quite there. So on that, any financial questions before I move on to the operations point?
So I would just add that, kind of getting back to Megan's question about how on some of these we might be able to move that dial. Are we giving it enough of its just due in order to be able to turn some of these in the right direction. And maybe it's just more a statement for the board of where you might need us to be. I'm your tour guide to make sure that that happens. But we want to make sure that we can draw in every dollar and then some into the region that we possibly can. And the reason that our board is structured the way that it is that we have the decision makers to be able to move that dial seated around this table. So maybe more just a statement, Trisha, than more than that, but an opening to the board.
Tammy, do you know if I recall that the Operations Council co-chairs were planning on coming on a more regular basis to the board, and that's part of their charge is quality incentive metric performance. And I want that has been, I think, an opportunity for this board in the past to have those conversations.
So I am not aware of that, but I think that that's a great idea, because I do recall from the past that was that's the lever that gets pulled. We can wave the wand, but most of us seated around the table are not actually doing the work. And so Carmen, is that something that you are aware of? And so okay, wonderful.
Yes, there is an operations council that's forming and, really trying to hopefully guide this work along with the RIP and the QIMS and putting those value-based information into that space. So I don't know, Linda, if you wanted to add anything to that.
No, not at this time.
Okay, sorry, I thought you unmuted, so.
So Leslie, I will look into that further and make sure that we have, because the Ops Council I know has been a strong partner in being able to really lean in on the areas in which we need to be sort of elevating the discussion. So thank you. And thank you, Carmen.
Yeah, I would just add, this work is really done at the member level with the population health team. And they are meeting monthly with our provider partners. Although we are yellow, there's a lot of tremendous amount of engagement in that space. And I also do attend that QIM Operations Council where these are being heavily engaged. So I know there's a lot of competing priorities in the clinics. So when you hear of this work or, schedulers, it's a lot to balance in a workforce shortage space. So just continued support that can be offered, I think, is where we're at this point, and know that this work is being really dive down again to the individual members and making calls to those gap lists. There's a lot of success also happening in these spaces. So despite all of the current barriers.
Trisha, I had a question. This is Linda Johnson. Are the other CCOs struggling in the same area? Are we facing the same issue with workplace? Or are they facing the same issue with workplace shortages? Or is this something unique to our region?
Leslie Neugebauer oversees all the CCOs. So if Leslie, would you mind leaning into this space?
Yeah, no, I'm happy to. And I see Rebecca nodding her head quite a bit. This is definitely a statewide issue as far as how it impacts quality metrics, which I think is what you were asking. Our other CCOs are still performing at reasonably high levels given even workforce shortages. Central Oregon, where they're a bit of an anomaly for, again, just our 4 CCOs, is lower performance on the quality incentive measures currently. And then also, as you know, we didn't meet the emergency outcome tracking metric for the COVID vaccine for Medicaid, and all of our other regions did. Rebecca, did you want to add anything on that?
Yeah, as Leslie said, pre-pandemic, many of the CCOs were performing very well and had developed very robust programs around this metric and were performing very well. Columbia Gorge, Pacific Source, and the Columbia Gorge region was performing exceedingly well, had a great program going, but with workforce shortages and other constraints, most CCOs are underperforming in this space right now. There's actually going to be a learning collaborative at the QHOC meeting on Monday, the healthcare quality meeting on Monday, run by OHA, where different CCOs are going to talk about challenges that they're facing, strategies that they're putting in place, because it is common across the board that CCOs are struggling. So there is some technical assistance happening to try to help CCOs support each other actually in trying to put different strategies in place in this time where many folks are facing workforce constraints, to try to see if they can boost their performance.
When you think about the COVID metric missed last year for Central Oregon, we were the only Pacific Source CCO to miss that metric. So when you think about how that could be linked to well child checks and immunizations, there's a very close relationship in those spaces, with people being vaccine hesitant and then that flowing over into those other two spaces. So that is more of our Central Oregon uniqueness that we are trying to overcome in that space, and it's going to take all of us.
And that's been a theme that we've had in this region even before COVID. And so, you know, I would say that that's just a hurdle we've been challenged with for a while.
Yes, and it exacerbated with the system under stress. Yes. The remaining two are operational metrics. I don't have any current data to share for the 2021, so I would just say continue, read those, know that we have work in progress. We are confident in our current space that we are, although without new data, that we are meeting these metrics and on track. So with that, I will conclude and ask if there's any more questions in this space.
Okay, looks like you did such a great job. We don't have any questions. Thank you, Trisha, and thank you for the comments that were raised. And Carmen, let's get together. We'll chat about Ops Council and having a maybe a better linkage into the board work as well.
Sounds great. Thanks, Tammy.
Of course. Okay, so next on our agenda, it looks like we're going to be bringing back the data piece. And so Gwen, you're off the hook. And let's go into a topic that came about between the last meeting and this one. And the topic is around gun violence and the connection between public health. I want to start with recognizing the sensitivity of this topic first, and appreciating the trust and respect that we have for one another to be able to have this kind of a conversation, as well as our role as thought leaders and decision makers in the public health and health realm for the region. We as a society have a history of affecting change in a lot of different ways within community, everything from bike helmets to seat belts, to tobacco use, driving under the influence, whether that's with medications or that's with other substances. As many of you likely know, the CDC and the American Public Health Association recognize that gun violence, both homicides and suicides, is a public health crisis. And there are a number of efforts that communities can engage in to address this. And many of those do not touch upon the one which is the most polarizing, which is about firearms in general. And so some of those community-wide efforts could be everything from supporting community planning and implementation of community safety plans. Could be supporting our schools, you know, thinking about some of the options that are happening there. Trauma connection and services, so expanding access to services, culturally competent and coordinated social, emotional, and mental health supports. Could be things such as establishing health systems in which violence prevention is a health system responsibility and something that's actually tracked, monitored, and the data is collected. Could be investing in communities to promote resilience and mental health and well-being. Could be exploring pathways between gun violence and harmful norms that have been brought about maintaining power and privilege. Could be exploring linkages between anger and gun violence. Could also be something as much as reducing concentrated disadvantage and investment in employment opportunities. So being able to make sure that people have the ability to engage in their community in a way to where they are feeling a sense of place, a sense of feeling that they belong in community. So there are a number of ways in which communities can get involved. And so I wanted to bring this forward and open a discussion. We fund a number of local initiatives over a variety of prevention efforts and trying to address a number of important topics that are happening within our communities. And so I want to pose a few questions and open this as a topic to discuss and see where you'd like to take it. The first question for me is our current work touching on this topic? Is this something, to my knowledge, it's not something that we are currently talking about, but would feel that as thought leaders in this realm, it seems that maybe we should be. And then next would be, what is our role as a board of directors? Is there a role for us? And what might we do to advance prevention, education, or awareness around this topic as well? And so I want to turn it back to you as our board. I think this is maybe a better conversation if we are in person, but barring that, I feel a deep sense of responsibility as your tour guide and chair of this board to bring this topic forward and make sure that we are doing our having our space to be able to recognize this as a challenge that's happening. And as uncomfortable as some of these questions and conversations can be, we are not sitting in a space where we are needing to talk about an event that's happened. We have the good fortune to be able to talk about this as a community and look for ways in which we may be able to leverage ourselves or lean in to provide some preventative or other opportunities for our community and our region. So I'm going to pause there and see if anyone would like to also share thoughts, or if this is something that you would maybe like to develop a small committee to see what it is that we could be doing and bring options back, or if maybe you'd just like to talk about it today.
Well, Tammy, thank you so much for bringing the topic up. One of the statistics that I wasn't aware of is that gun violence is the #1 cause of premature death in our country. And when I think about the role of the Health Council and creating healthy communities and really trying to get upstream and think about prevention, I would be really curious about what a role might look like for the Health Council in thinking about prevention. And I think, we did our last regional health assessment and plan. I don't think we looked at statistics and data around gun violence to inform our efforts. I think as you listed off some of the ways you can think about prevention that have impact, we probably do have some things that are at play that touch on some of those areas. But I would be curious, is there a way, and maybe Carmen, we talked about we're going into our regional health assessment, could we consider also looking at some of the data around this? And as we go through our process, does this become an area of focus for prevention as we look to our next plan as well? So that's kind of, as you're talking, kind of where my head is going. But would love to hear others' thoughts too.
And Megan, thank you for bringing this forward as well. I wanted to just draw Rebecca's comment to the forefront that we are doing a project related to the sense of belonging within our region. So thank you for that. Others, Paul, I think I saw you go off mute.
Yeah, as the education representative here, and understanding that gun violence obviously does not just impact education, but most recently it certainly did in a horribly tragic way. one of the things I would point out in answering your questions, we did fund the culture of care work. It's been a few years now. I think it was 3 years ago. And that was about helping to create trauma-informed supports throughout the school system. So as we talk about upstream and we talk about prevention through the schools, that is something that we have done. And we continue to do. As far as education itself, we are in Central Oregon. We have a student threat assessment system in place, and again, that doesn't speak to what happened, for example, in Buffalo and places outside of schools, but would speak to that. And I wonder if it makes sense to have more conversations between us. Well, that is to say, what education is trying to do, not entirely on its own, but within its own resources. And are we speaking the same language? There is the Safe School Alliance that has been in place for since Thurston, actually, and that's 22 years, 23 years, something like that, sadly, maybe even 25. That is about having a conversation between the various sectors, from law enforcement to education to the DA's office, et cetera. And I'm wondering if we have a seat at that table, and I wonder if we're contributing to that conversation. So those come to mind. As far as the role as a board, I first of all share Megan's appreciation of you bringing this up and having it be something that we should be asking that question as you have, and I think kind of from a policy level, I appreciate your notion of let's be careful, let's be somewhat careful there, and I think as the Health Council, we also can't avoid it, and so I think. You asked, does it make sense to have a committee or something of that sort? I think it makes sense for us to have this be something that is more than just a conversation today. And whether that is a subcommittee, whether that's working through ops or some of our other systems, I think any of those are possibilities, but the conversation can't stop as soon as we finish in 5 to 10 minutes, if that. So I'll stop there.
Paul, thank you very much. I appreciate that. Katie, dive in.
Thank you. I'm trying to find my square to see if I'm on camera. I am. Okay. Hi, everyone. Thanks for giving me some space. And thank you very much for having this conversation, because as Paul so stated, this is another one of those really complex issues that absolutely cannot be addressed by just one sector or by one group at a time or piecemeal together. It really does need to be a collaborative effort. And so I think this space, I'm really proud of us for having this conversation in this space. We do have some building blocks in the community, at least that I'm aware of, and there's probably even more that I'm not aware of, because I do think that there are individual sectors that are working on this, and so I'm probably missing some, but a space that we have made ground is in the suicide prevention realm, and where we've done some research. I think a lot of you are maybe familiar with the work that Dr. Susan Keyes did around People Who Love Guns Love You. That campaign is really around the issue of suicide, but it dug into, and I think laid a really good foundation for the approach of having a conversation about the topic of guns. And if we're going to make a dent in this issue, and this is really common language in suicide prevention, but we have to talk about means. So if we're talking about gun violence, the guns are the means. And we can talk all day about mental health and protective factors that yes, we have to do those things. And we can't shy away from the means of this issue, knowing as well that that is incredibly complex and challenging and difficult, and we have to meet our community where they are. And but I wouldn't want us to shy away from it in the context of health and safety. So I see things popping into the chat. There are lots and lots of resources happening at the state level that I think we could pull in and gather. And I would be happy if a group does convene, I can do some research and pull some things in. I'm also on a work group at the national level. The National Association of City and County Health Officials has an injury and violence prevention work group that makes policy recommendations at the federal level. And we've been talking a lot about this issue right now because it's a hot topic. But I'd be happy to pull some of those both state and national resources together, whether I'm at that table, I would love to be. However, this board wants to move forward, I'd be happy to support in any way you all would like me to. But thank you for having the conversation.
Thank you, Katie. And for those that maybe are not aware, Katie is the public health director for Crook County. And so we're fortunate to have her step into that space after Muriel retired. So just to make sure that folks know. So Linda, dive in.
Yes, I'm all charged up and excited about this topic. I just yesterday came back from the Rotary International Conference, which was held in Houston, Texas. And now that Rotary is down to less than 8 cases worldwide of polio and its eradication of polio, they're looking for what is the next big thing worldwide that Rotary and its 1.4 million members can devote itself to. And the subject and topic of peace is huge in that community right now. So I attended a breakout session that was led by Dr. Gary Slutkin, who's with an organization called Cure Violence Global. And he said that rather than focusing in just on guns as the issue, that we look at violence and all the levels of violence, whether it's community violence, whether it's bullying, whether it's suicide, that we look at it as a contagious disease, because it is, violence with or without a gun occurs in waves. We have clusters of it. The more exposure you have, it's dose related, the more likely you are to be traumatized and to follow up, copycat sorts of things. And that even like COVID, if you can interrupt transmission and then implement behavior change that causes people that are impacted by violence with or without guns, to really look at what makes some people susceptible. It goes back to belonging, which we're already doing work around. And it just organizes a whole cluster of violent activities that we can, that I think everybody can sort of align around. Everybody's worried about kids' safety in school. Everybody's worried about teacher safety. Everybody's worried getting into major groups. Large groups, because someone may have a gun or someone may have a bomb. So if we can look at the common fears of the community and start to build common ground on, no one likes violence, but rather than get sidetracked onto guns as a particular issue, it gives us a way to approach and communicate to the issue, and a public health approach to maybe start to turn it around, interrupting transmission, doing some behavior modification, and then really reestablishing community norms about what behavior do we tolerate as a community and what do we not. And the risk of being polarized around guns minimizes our ability to come to agreement and set a community norm around this is a non-violent community. So I was really intrigued. And so I love this whole topic, and not just as a Rotarian, but just as a health professional. I think it's something that's right at Public Health Sally. I would feel that the Health Council would be neglecting a key part of its mission if we didn't move forward with some sort of a working group to make recommendations to the council on what areas we focus in and how we do that.
Thank you for that, Linda. And what a great opportunity it sounds like you had. I'd like to propose, it sounds like there's enough interest for us to carry this forward, at least to have a small subcommittee bring back maybe what it is that we're currently doing. Naturally, as a board, that your role is governance, you wouldn't know each investment that we are making in each one of the work groups. And so it might be good for us to get a feel for what the investments are today. And then the Safe Schools Alliance, I'm remembering Mike Dugan, Paul, and just in those meetings and what a benefit that committee is. And maybe there are some places where we might be able to invest some of our leadership time in being able to draw these things together. And so is the group willing to support having a small subcommittee come back with some areas in which we might want to consider for involvement or investment, and maybe some options as we go forward? And I see a thumbs up and some heads nodding. Okay, so next, Linda, you said you're passionate about that, and it sounds we have Katie who's interested as well. Certainly wouldn't have to just be a board member. So Katie, we'd love to have your investment of input and time as well. So please let it be known if you're interested, but also if you'd like further time to think about it. I can ask, maybe Carmen, we could send a message back out just saying, especially with some of the resources that have been popping up in the chat, we could follow up with a casting of the, please let us know if you'd like to participate. Megan, go ahead.
Oh, I just said I'm interested in the chat.
Oh,
sorry.
Yay. Great.
Before that plan.
Well, thank you. And I don't want to, we are intentional in the manner in which we have these conversations. And I just want to celebrate that we are intentional about the work that we do. And I want to thank you for being that kind of a group that we get to work with, because these are, as we were talking about earlier, if some of these topics were easy, they'd be solved. And this one's not. But also I can think of a number of communities that if we had this conversation, it might not go quite the same way. And so thank you for being in that space of just recognizing our role and the importance of us determining the space in which we might be able to affect change and support our communities. So other comments or statements or things that you'd like to bring forward? That's it sounds like we'll have a small ad hoc committee and we'll bring that back. Justin's been super quiet today. Okay. Well, if there isn't anything else, let me get back to my agenda. I'm not sure that we have anything other than we will not be meeting in July. And so we will be looking forward to seeing everyone in August, and maybe we can pull this small group together in that space in between the two and be able to present something in the August timeframe. Okay, so with that, Carmen, we are so grateful to have you on board. And I've received so much feedback already. People are just excited to meet you and really enjoy spending time with you. Thank you to the Health Council team for all the hard work, especially in putting everything together last week. And just thank you for your commitment to our community and to the region, everyone. Really appreciate your time. So we are adjourned.
Thanks everyone for being here.